Don Pelto. I have Dr. Michael Chin here. He is a podiatrist in Chicago. Michael, thanks for joining us.
Thanks for having me.
You're welcome. So I want to talk today about you've been doing podiatry 17 years. The last 12, you've been doing more sports medicine within podiatry, and that's kind of the niche you chose. So this is a lot of maybe young doctors or doctors that are wanting to work on their practices. What kind of made you choose that niche within podiatry, and how has it been going for you?
Niche-wise, it's been great. You know, from a most recent standpoint, I was mentioning earlier, is that things like COVID in the middle of an urban setting in the city, things have been a little bit difficult just because volume-wise, people aren't coming to their offices. But prior to COVID, we do really well. It's been a strong, building practice with obviously runners, and Chicago Marathon is such a huge emphasis here in the city. It draws obviously millions of people as spectators, but then also about 45,000 to 50,000 runners from all different levels to basically take on a task of running 26.2 miles. So, with that in mind, a lot of the training programs that we work with actually developed a relationship with us to try and help get the runners to the start line. So, as kind of sports medicine goes, it's a great field. I think it certainly is a thriving aspect for podiatry. We do see people outside of running, which I think, a lot of people, when they look at my practice called the Running Institute, that's all they kind of know and understand. But we do see ballet dancers, we do see basketball players at the collegiate level and a UA level. We see baseball players. So I mean, we do cover the gamut. But as far as the primary part of our practice has been working with runners from the very beginning stages to the elite. So.
Now, you mentioned before the way you kind of did it, and a lot of people, they might want to develop their own niche. And you mentioned a little bit about relationships. Is that with primary cares? Is it with teams? What type of relationships would you recommend for someone starting out?
Sure. Relationship-wise, we developed a really nice relationship with physical therapists. Interestingly enough, back about a year and a half ago, physical therapy was not able to get referrals directly. They were able to, procure like a visit based on, again, just a free screening, but they couldn't actually get, physical therapy sessions covered by insurance until they saw a physician. Fast forward, obviously, to this past year and a half, physical therapists have actually developed a direct relationship with the patient where they can actually see a patient without having an insurance referral. So we developed a relationship with a number of our physical therapy groups here in the city, both small and large. And with that, we actually were getting the screens for those patients, whether they needed the referral for physical therapy or not. They said, hey, listen, Dr. Chin, the Running Institute works with athletes. You have an athletic injury. Let's get them in to see Dr. Chin. So we had a direct pipeline with my admin who would basically schedule within 24 to 48 hours for that particular patient. With it, obviously now where they have direct access, they have about a 2-week window of time that they can see a patient. If they're not seeing marked changes in that patient's care and their outcomes, then what they can do then, because we're still on their speed dial, that they will actually develop then that connection to my admin and then get them on the schedule. So regardless if it's a direct access or not, we still have that relationship driving some business back and forth. And I think, how we do it now is we have shadows of physical therapists or athletic trainers from programs that will come in every week from different groups, and we set them up on different days so they're not overlapping, and then, get to know them. If we get to know them and they get to know us, that relationship obviously builds. Some of my best friends are physical therapists who we've developed relationships over the past 17 years. So
I think that's a great, having them shadow. I think anytime medical students, residents,
absolutely,
and because they'll develop their referral patterns and the basis of their knowledge of podiatry is and what you can show them, you can teach them. That's great.
We started doing some work too with sports medicine fellowships here in Chicago. So, internal medicine and family practice medicine docs can actually go on to another year of training And with their fellowship, they actually have a section in there that requires foot and ankle podiatric evaluation. So by virtue of that, we developed with two of the sports medicine fellowships here, that relationship. So now we have a fellow that'll rotate for like a month, month and a half, and they come in every week and they do, foot ankle assessments. We do talk about obviously the treatment protocols that we instill. And what's interesting is that, some of them are super interested in kind of taking on that, foot and ankle pathology. Some of them want actually just a referral, pattern so that they can develop somebody who knows that in their practice. They may have a focus again for themselves, that shoulders or knees and things like that. And then the foot and ankle side then becomes a referral to, for example, myself or maybe one of my colleagues. Mm-hmm. So again, just strengthening that relationship is really important.
I think that's key. Michael, in terms of, let's talk a little bit about the patient base. Just because you do sports med, is that maybe a segment of what most podiatrists do? Are we talking Achilles tendonitis, stress fractures, plantar fasciitis, posterior tib, peroneal? Is that what we're talking about when you're talking sports med, or is there other stuff way out there that you're doing as well?
Yeah, so most of it is, I would say, the typical stress fracture, Achilles tendonitis, plantar fasciitis, the plantar plate tears, the orthopedic issues, and not all of it's surgical. I do have a decent surgical practice, but we try obviously methods that are non-surgical. As sports medicine goes, most of those patients are looking for avenues to still maintain a level of activity while they're going through a therapeutic treatment. So one of the things that we started working with is Shockwave, and Shockwave has been around forever. I mean, it's not a new technology, but there's new techniques, and I think the techniques are starting to develop in the space of how can you treat a stress fracture faster? Can you get a patient out there in 2 to 3 weeks versus 4 to 6? And that's always the name of the game for most of our athletes, is that they want something that's going to put them in the game faster, safer, and then also without recurrence. So we've been treating patients with stress fractures with Shockwave treatment, more of a focus wave therapy, which is different than that of kind of the one that I would say most people see out of the Storts products, or even the Zimmer products. But the Storts product actually then developed this focus wave unit that actually is more kind of a pointed version of direct access to stem cell activity, bone, blood flow, and things like that. We use that in terms of a weekly basis for about 3-4 weeks, and in some cases after 2 weeks, the patients are actually not only symptomatic free, but also stabilized as far as their stress fractures go, or stress reactions. We also have been using amniotic injections as part of our protocols for things that are acute with a chronic overlay. So for example, like a plantar fascial tear that's chronic, but there's an acute access to, or acute situation to that plantar fascial pain. And I created a protocol, which I shared with Paul Hobro, who was on maybe a few months ago. And by virtue of kind of triggering the adult stem cells, but then also taking care of the scar tissue, you actually have a reparative process that actually is synergistic. And when we see patients, in our practice, a lot of patients have been second, third opinion patients, and they're kind of wondering what it is that's going on. There's been no imaging, maybe no ultrasound or MRI performed. And when we get that imaging, it lights up like a Christmas tree. There's plantar fascial partial tear, and they've been treated as a plantar fasciitis case. So with that protocol, we're batting close to 95+% to get patients not only just ambulating, pain-free, but physically getting back to their athletic activities. Some of these are ultramarathoners to, Ironman triathletes. I mean, you name the different endurance athletics. We have patients probably in that treatment protocol that have actually succeeded and have done well and not coming back for that same condition.
That's awesome. I think that's so valuable for those that are listening. Let's focus, Michael, a little bit more on this protocol. So a patient comes in, maybe second, third opinion, possible plantar fasciitis. Is it X-ray, then ultrasound, then MRI? Is it, what gait analysis, orthotics? How does that all fit in for your protocol?
Yeah, so the first thing I always say is diagnosis is going to lead you down to a path of good treatment. So if you have a good diagnosis, that's going to take you places. I probably am one who orders an MRI a little bit more kind of frequently because I kind of want to know, especially if somebody's been kind of in a spin cycle of 2 or 3 different docs, like what is it that they didn't do? It's really easy to kind of go back and kind of be a detective and say, okay, this person didn't do this, this, and this. It's nothing against the way that they approached it. It's just, if their patients aren't getting better, what do we need? So most of the time, I would say if things are pretty clear cut, I would do an ultrasound in office. But if there's something that maybe kind of on that verge of maybe it's a stress fracture, or if there are signs that maybe there's a bone stress injury kind of near at the calcaneal level, I'll get that MRI. I'll get the MRI to make sure that there isn't bone edema or some other pathology going on. We do have ultrasound diagnostically in the office, and more times than not, for somebody who doesn't have those bone kind of pathology findings, I would stay the course and do the ultrasound, and has been pretty successful to identify plantar fascial tears or partial Achilles tendon tears for that matter. So
perfect. And then let's say they come in, you do see the hypoechoic around the ultrasound, or and then it's right around the insertional portion. When do you recommend? Let's break it down for people. When do you do just Shockwave? How many sessions? And then when do you do Shockwave plus Amnio?
So if it shows just straight up plantar fasciitis, thickness of the plantar fascia that's above that 4.5 to 5 millimeter mark, with no signs of a tear, I go straight to Shockwave. Shockwave 4 sessions to 5 sessions a week apart. We have the benefit of again having both focus wave and radial wave, which kind of I would say is kind of the two-headed dragon that gets after that plantar fascia, both blood flow wise and breaking up the scar tissue. But if you have just a straight focus or a radial wave unit, which is more common amongst our colleagues, you're probably looking at about 6 sessions of Shockwave. If there's any sign of a tear, partial tear, typically at the central band, sometimes you'll see it on the medial band, but a lot of times it's central band plantar fascial tear, I go to the combination of treatment with both Amnio and EPAT or Shockwave. And protocol-wise for Shockwave, first I do, again, a week apart. So those are done basically in successions of 4, 1 each week for 4 weeks. On the second session, after I do the EPAT, or Shockwave, I actually will do the amniotic injection.
That's what I do.
So it's kind of like prepping the soil. I kind of think of it as like, got to till the land to get the soil prepped. Once you get that Shockwave going, the second session, you do the amniotic injection. And what they find is that, for example, and actually this was something that the folks at CureMedics and Storts found out, is that if you took, for example, stem cells, you spin stem cells down from a adipose tissue, and you shockwave the actual stem cells, you put the unit up to the actual test tube and shockwave it, they actually increase the number of stem cells within the shock in terms of the tube. So the volume actually increased in terms of stem cell count. When you kind of take and shockwave the tissues and again get that blood flow, I think that there's a synergy between that and the adult stem cell activation, that you're actually getting that blood flow kind of flowing to that area on top of the stem cell activity. And then after that, I do, for most plantar fascial tears or even partial Achilles tendon tears, I'll immobilize them for about 2 to 3 weeks in a boot, just to kind of keep them off it, remind them that something's going on, and also that it's a severe enough situation that they shouldn't be, running around in it. And it just gives them a reminder. And for that, I do think that too, it allows the tissues just to calm down enough to where they're just not, again, striking up this constant tug of war on the plantar fascia or the Achilles.
Yeah, I think that was very beneficial for the young doctors, just to, to get into the mind of someone that does it all the time. It just, you have this treatment protocol in your mind, and a lot of people, they're just trying different things. And I think we have to have these delineated protocols. It makes it a lot easier in our office. Perfect.
Yeah. And, everything comes and boils down to, again, evidence-based. And that's the one tricky part, is that, a lot of the, stuff that we have done is literally based on what's anecdotal. So we have a fellowship starting, a sports medicine fellowship starting actually at the 1st of October. And one of the goals I'm looking to have my fellow do is to actually put those numbers together and put it on paper so that we can show the outcomes.
Yeah.
I can say 95%, 96%, but really what it boils down to is, can that be replicated by other people?
Yeah.
And we do have actually a number of my colleagues out there who are actually replicating and getting those same numbers. So that's a positive, but we do need to get those details on paper so that, again, published, papers are really, again, proper levels of studies are really important to kind of showcase that and get that information out.
Now, just kind of poking and prodding a little bit, we're talking level of evidence. Let's go into orthotics, where those fall into for treatment. Is there enough evidence? How do you use them in your treatment protocol? Is it every fascia, every Achilles that gets them, or how do you determine?
Obviously our colleagues would probably grin and, kind of shake if I said this. I don't have orthotics for every patient. I do believe that there are certain devices that work better than others, especially for athletics. Softer devices, there are some studies out there that show, from a military study standpoint, that hard orthotics can actually increase shock to the foot and to the lower extremity by about 3 times. So 35% or 37% versus 12%. So, when I look at orthotics for my patients, for a person who has plantar fascial, pain, I do use orthotics actually quite often. That's one. I can disperse the pressure away from the heel. I can take some of the tension points away. I do a deep heel seat to kind of cup the heel. For Achilles tendons, I tend not to, and I wonder if sometimes the Achilles tendons actually feel better because you're putting a little bit more of a heel lift, heel to toe drop in the shoe than just putting a wedge. Would that be as successful, right? Not every Achilles tendon, patient requires, again, that supportive element. Because there's no correlation, to my knowledge, that pronation actually creates an Achilles tendonitis. I think Achilles tendonitis is driven by, again, calf, hamstring, complex hip weakness and disability. So when it comes to the foot and ankle side of things, it does become more case-to-case basis. If they have other pathology that's kind of driving along with Achilles, then I'll maybe do orthotic. But I like I said, I use more of an EVA device. I find that EVA in tandem with like a myolite or memory foam tends to work really well. There was an instance where LeBron James actually took his orthotics out of his shoe to give his shoes to a kid. And all of a sudden, like on LinkedIn, people were kind of blowing it up. They're like, what kind of orthotic is he using? It's, it looks so different. It's not polypropylene, blah, blah. It's like, that's an EVA device. It's blue EVA with a cork wedge on the lateral aspect for ankle stability. And if you put a softer device in and you try it, you will know the difference. I mean, you still get a functional aspect to it, but you'll know the difference in terms of the way that it, kind of eases the transition from heel contact to midfoot to forefoot. It really does kind of disperse that a little bit more evenly without having that kind of teeter-totter effect that a polypropylene device has. So
that's great. Let's go a little bit more into insertional Achilles versus like the non-insertional. In how do you treat them differently? Do you use Amnio on both of them? Shockwave?
Yeah, so I would say for the insertional, I probably will go more towards Shockwave Amnio combo because that is a definitive pull-off type scenario. When you have the patient who has the traditional Achilles tendinosis, I would say Shockwave. And the one thing that we have to delineate too is that some people will have a peritendinitis, right? They have this kind of inflammatory process around the Achilles tendon that actually doesn't involve the Achilles at all. And what I found is that Shockwave does not actually improve those symptoms really at all. And what I've been doing, which is something one of my orthopedic colleagues has been subscribing to, is almost like a debridement where you take a local anesthetic and you run it into the tendon sheath. So kind of finding that fine line with an ultrasound to kind of delineate the Achilles from the tendon sheath, it actually separates the fibers of the tendon sheath from the actual Achilles. And those patients have done really well with, again, this debridement type treatment, local anesthetic. You're looking at lidocaine. Typically, I don't like using Marcaine in and around the Achilles tendon, but lidocaine 2%, and you just basically run it along the Achilles tendon sheath.
There's a similar, I think in your training, I think if you did similar to my partner here, Neil, like a flexor hallucis longus as well, a lot of those tenosynovitis can respond well to something like that.
Absolutely. And sometimes if you put it into the first MTP joint, instead of actually trying to, put it directly into the FHL tendon, you can actually get a little tunneling from the first MTP joint down into the FHL, and patients will actually respond really well to that. The windlass mechanism activates them.
That's awesome. Great. Let's kind of move a little bit back towards doctors that are starting out. What are some of the best advice that you ever received, kind of when you were in training or at your conferences, that's really helped you out your whole career?
Yeah, I'd say do what you love. If you're not going to love what you do, man, it's going to be a chore. And people do not, when they come into our practice, residents and students, we do work with the folks at Scholl, and we also work with the folks at Illinois Masonic. And what they notice, comparatively, and I'd say to some of my, colleagues, is that some people are just in the grind, right? And if you enjoy what you do and you love working with, whether it's diabetic or a sports medicine, patient, you have to listen, and you have to kind of understand what their feelings are towards whether it's treatment or their injury, right? A lot of the things that I've had patients come in for, actually I've had. So I know firsthand, like what plantar fasciitis feels like. I know what, for my elbow, for example, I know what elbow tendonitis feels like. And, having my orthopedic chiropractor who's here treating my elbow, I know what that, entails when it comes to Shockwave. So kind of having empathy, I think is a real big one. And not everybody's coming in to try and, just, cut the corners. They want to have obviously a long-term, long-standing outcome. And that's important. I would say, don't be afraid to jump in and talk to, whether it's your orthopedic colleagues, your internal medicine docs, the rheumatologists, like get in front of them. And, again, it's hard to say, just be confident and go in and say, this is what I do, but kind of say, how can you help their patients? How can you be in the team to kind of say, I can take the lead on this. I know what my boundaries are. I'm not going to exceed the boundaries. I don't do flat foot reconstruction. I don't do, major, ankle, subtalar joint fusions. I farm that out. I know what my limits are. Mm-hmm. And that's a big one. Like, we come in and guns blazing, we've done all these, years of residency and years of practice. And after a while, I think we all kind of want, the same thing. We want to have a successful practice. We want to be able to do the things that we want to do. And we want to also have a family life, hopefully, yep, and retire at a nice age. If you go in, and you want to do all those big cases, God bless you, because there's obviously a longevity of that patient that's going to be on your, schedule for a lifetime. There's going to be obviously the, ups and downs of, patient management, going into the hospital, having to manage obviously very tricky patients. But if that's in your wheelhouse and you love it, then do it. But for me, like, I just didn't love it. I did a ton of call. I did 3 years, of call in residency. Did call, 2 o'clock in the morning, fractured jumper coming off of a fence, getting called in for a case that, literally the guy was drunk, right? It wasn't in my wheelhouse. So, kind of pick and choose, I would say, what you like to do. And then don't be afraid to start a practice. And that's the part that, I think, I was told that I wasn't going to make it in Chicago. I had some attendings ask me why I wanted to open up in a big city. I was like, well, why do you guys practice in a big city? What's the allure for you? And, they couldn't come up with an answer. They're like, well, we've just been doing this a long time. We've been doing it for 20 years. And I'm like, well, I think I can do it too. So I literally opened up my, location, and, one thing after another. It started out with 5 patients, the first week, and then it built up, and, to the point where you're seeing a hefty number of folks. And don't be afraid if you're not wanting to go the route of joining a big, group practice or a multi-specialty group, that I think the pendulum's going to swing. I think the pendulum's going to swing back to where the practices that are developing, again, kind of that niche, are going to be able to survive. Like I said, COVID has a whole different, take on things, but, when things hopefully normalize, that will start to kind of swing back. Insurance companies are going to, I think, start to see that, maybe the cost effectiveness of, taking you to a big, practice aren't going to be as cost effective. It may be, more cost effective to see the person as a single practice,
Mm-hmm.
Based on contracts and things like that. So.
Yeah, I think those are great tips. And Michael, I want to appreciate your time here. If people want to learn about doing more sports medicine in their practice, where do they learn more? And if people, maybe they're young and want to learn about your fellowship and learn more about your practice, how can they get that information?
Sure. So the AAPSM is a great resource. So it's the Academy of American Podiatric Sports Medicine. They host, and usually there's an annual meeting that we put on, not I, but the group puts on, and it brings all the minds together, both podiatric, internal medicine, sports med, physical therapy, and puts them into a single, place to basically pick their brains. And it's a very open access conference, which is great. I mean, yes, there are lectures, but there's a lot of camaraderie. Like afterwards, you can go and have a sidebar conversation with the speaker and really pick their brain about stuff. When it comes to our program and the fellowship, you can email me directly. It's drchin, CHIN, at therunninginstitute.com. It's a long tagline. I apologize. But yeah, you can certainly email me anytime. I'm pretty good about getting back to folks. Just put in there, you heard this, show through Don Pelto, and I'm more than happy to answer those questions. That's something I think my wife is probably like, what are you doing? I'm like, well, I'm answering an email from a student who asked me about something or other at like 11 o'clock at night. So I'm more than happy to kind of take on answering the questions. It's fantastic to again know that there are people out there who are like-minded and have a similar interest. Yeah. And if I can help them advance, because I didn't get that when I was coming out of residency. I did not get that kind of vote of confidence like, hey, yeah, open up shop in Chicago. They were a little bit less than happy about that.
Yeah. Now you have a podcast as well. Tell us a little bit about that.
We do. So Rob Conanello, myself, Matt Word, and Paul Langer put together a podcast called RPM2, where sports is fitness, and it literally puts people who, again, had spoken at some of these meetings at the APSM on a podcast. So you can get guys like Jay Deshari is a physical therapist who's phenomenal. Mark Cucuzella. We have, folks from Fleet Feet, for example, who talk about kind of the, area where shoes are going nowadays. So it's a really great avenue for us. We kind of formed it out of COVID because we had a little extra time. But now we're actually hosting this on Fridays at 1:30, typically Central Standard Time. And then it goes into podcasts and also on YouTube. So the folks are editing it for YouTube. So if you take a look for RPM2, it should pop up under both headlines. So
cool. Well, thank you, Dr. Michael Chin. Appreciate your time, and I think it's going to be a great interview. We're great.
Thanks, Don. Thanks for having me again, man.
Hey guys, thank you for watching Healthy Living. You're going to find a few links here I'd like you to click. One is to subscribe to this channel on YouTube. Also, you can learn more. There are some videos here you can see.